We're doing a YouTube live today, February 19th, 2020. This one is sudden cardiac death, the Hollywood myth. Now, that sounds weird, right? I mean, we know that happens a lot. We'll talk about it. I'm the Hollywood myth. That's a quote from, a sort of a quote from Harvard Health a few years ago. Also, as usual, we'll take questions, talk with some folks that dial in, participants. On errors today, I'm just going to cover something briefly about monk fruit. Somebody asked me about monk fruit last week, and I made a comment that I started dogging monk fruit. I shouldn't have. It's actually one of the better non-nutritive sweeteners. And actually, we will talk a little bit about the whole issue of non-nutritive sweeteners and what your brain looks like on sugar and even saccharin and the other non-nutritive sweeteners. We'll get deeper into that next week. We'll also talk about learning resources, the Orlando event. The book is getting closer to publication and release. And the webinars. We're doing a lot of work on webinars. We continue to get great reviews from folks that are participating, and we're looking at a way to clean that up, take that out of a pilot mode and put that into more of a production mode where we can make that available to a lot of folks. I'm going to go into presentation mode here. And the studio looks a little bit different today, right? We're down at Kiowa. It's one of my favorite places in the world. We have a place here on the beach. And yes, I would have loved to just retire here, but I would have been bored. And it's so much fun having an impact on people's lives. So that's why we're doing what we're doing with the channel, with the information services that we provide, and with the patient care services that we provide. So what you're seeing in the background is my little Kiowa studio. I didn't bring any of the camera or any of that stuff, so I'm on an ugly webcam. So let's get started. This is a quote from Harvard Health Publishing, December 06. It's the Harvard Health letter. Quote, "Sudden death isn't always so sudden. The Hollywood picture is that it's like a bolt out of the blue. The reality is it's more like real lightning, and real lightning is preceded by clouds, wind, and rain. In other words, if you think about it, you look at a clear blue sky and they say, you know, it's like lightning out of the blue. Lightning really doesn't happen out of the blue that often. It usually comes from, again, storm clouds, wind, rain, and really angry black clouds like you see on the right. So if that analogy holds true, can we recognize a metabolic storm and maybe even intervene, decreasing our chances of that lightning strike? I would say yes. And all of you have heard the story I'm getting ready to tell you, and I'm not going to spend much time on it. I've covered it a couple of times, and here's the point. 2 years before this date, Harvard Health was saying sudden cardiac death is really a myth. It doesn't come out of the blue. Well, this came out of the blue. This was in Washington, D.C., April 29th, 2008. Georgetown office, Dr. Michael Newman, internist to Washington's elite, 58-year-old non-smoker. Waist size was continuing to grow. It had gone recently beyond 40 inches. And that's something to think about. Blood pressure was controlled on meds, total cholesterol, LDL, all were fine. Getting worried about a couple of things and said, well, you know, let's do a stress test. They did the stress test. It was normal, breathed a major sigh of relief, and went back to work. 6 weeks later, after the stress test on Friday the 13th of June, 2008, collapsed. CPR was done by coworkers. EMS was called at 1:40, arrived 4 minutes later. 3 defibrillation shocks were applied, and he was pronounced dead at Sibley Memorial Hospital. It was in there was a large clot in the left anterior descending, the widowmaker. This is Dr. Michael Newman. He is in a NBC Live announcement. He went to the emergency room to see if he could help with his patient that had died. One of his comments was, "We could have done a stress test an hour before he died. It still wouldn't have told us anything." So again, most of you know who I'm talking about, Tim Russert. I'm not going to go into the details, further details on that, but I will say this. Look, again, we all know that that was over 10 years ago. Aren't we better now at predicting heart attack? Well, shouldn't we be? Well, I mean, Davy Jones, Gary Shandling, James Gandolfini, these guys weren't planning on having heart attacks. Alex Trebek, Bob Harper, you know, Bob Harper did announce after his heart attack that it's LP(a). So here's the thing. Maybe there are things that we can do. Obviously, it's not stress tests, because most of these people had a negative stress test prior to having their event. And obviously, the bigger message here is, no, it may be over a decade since Tim Russert's death, and it may be, what, 16 years now, 14, 16 years since Harvard Health came out saying sudden death should be a Hollywood myth. Well, it's not a Hollywood myth. It's happening every day. We actually expected to see heart attacks become the #2 cause of death after cancer. Since the 1950s, 60s, there was a significant drop in cardiovascular disease death. Right before it crossed the line and became #2 with cancer, it started turning back and coming back up. And again, as you see from this Wall Street Journal article, it's a resurgence. Now, we think we're going to find that metabolic storm and predict that heart attack using stress tests. Obviously, that's not working. We're trying a lot of them, though. If my math is correct, over 8 million nuclear stress tests alone. That's only one of 4 or 5 different types of stress tests available. 8 million of them. Again, if my math is correct, we're doing 40,000 a day on weekdays. And most people that have heart attacks, a stress test would not have predicted it anyway, because a stress test is only going to show, this is a cross-section of the artery. This the red is the flows, the lumen where the blood flows. The yellow is the artery wall, and the white is plaque. And bottom line is, you're not going to see a positive stress test until and unless you get over 50% flow impact. Well, 68% of heart attacks occur in people with less than that, less than 50% occlusion. So it's obvious, just given the science and how the test is constructed, that we're not going to predict heart attacks with stress tests. But let's go back to that original slide, that original statement from Harvard. So it isn't always so sudden. It's a Hollywood picture that it's a bolt out of the blue. It's more like real lightning, preceded by clouds, wind, and rain. Well, obviously, it's not preceded by something on a stress test. Is there something else? Is there some other component of a metabolic storm that we can see? And I would say yes. Maybe there's cardiovascular inflammation. As we all know, it was not just the physicians, but anybody that read Time magazine as early as 2004. It was cardiovascular inflammation was on the cover of Time magazine. The surprising link between inflammation and heart attacks, also cancer and Alzheimer's. Still, what, 12, 15 years later, just a couple of years ago, cardiology interventions is still talking about inflammation for the cardiologist, but still, the standards committees haven't gotten their head around how to recommend to the cardiologists to deal with it. Meanwhile, again, people continue to die. So one of the things we're doing, and it gets back to the webinar program, we're getting a lot of great reviews. And what we're doing is we're offering cardiovascular inflammation testing. We're offering OGTT, oral glucose tolerance test, and insulin surveys. This is, you don't need to get, I don't plan to get into the details of what's involved with a cardiovascular inflammation test. Just wanted to show you that's one of mine recently. And what is inflammation? It's basically where you're burning this glycocalyx. This is a cross section of an artery wall. This is a nice clean artery with no plaque. The intima is that lining area. The media is the muscle, the smooth muscle that keeps the artery structurally intact. And again, this is the glycocalyx. A healthy glycocalyx is where the metabolic processes occur. Cellular fuel and oxygen is dropped off here, and cellular wastes are picked up by the bloodstream. So again, this is a critical place. As you see here, down below, this is a nice healthy glycocalyx, and then that's a glycocalyx that's been injured. And again, going hour after hour with insulin levels over 100 or glucose levels over 140, 160, 180, burn this glycocalyx, create injury to the glycocalyx of the endothelium, and then oxidized LDL starts passing through that glycocalyx, starts ending up as plaque in the artery wall. The plaque then is recognized by the immune system. The immune system starts sending in macrophages, T cells, lymphocytes, other immune system components. They attack this plaque, they digest it, they turn it into a liquid. And then there's only the intima layer between hot liquid plaque and the bloodstream. And if that breaks, you have hot liquid plaque touching the liquid blood, and that causes a clot. This is the clot here. The majority of this clot is broken off and killed that patient. Here's a different look, same thing, patient it's on postmortem, they've died, associated with a heart attack. And again, this is the media, the intima, the waxy component of the of regular plaque, and this is the hot plaque. So what causes that? By far the most common thing is insulin resistance, having a blood sugar 160, 180, over 200, hour after hour after hour each day, and not knowing it. The CDC said a few years ago, well, we've got 80 million American adults who have prediabetes. And yes, it does cause heart attack and stroke. They also said 90%, 72 million, don't know it. Well, here's what there's something bad wrong with that number, and they've gone back and changed it. Now they're saying maybe it's 125, maybe it's 150 million, and I would agree. There are even far more people that have, adults in America, that have insulin resistance, causing this metabolic storm, this inflammation, than they thought. And again, vast majority of these folks don't know it. The CDC originally thought it was 1 out of 3 adults. This information, that study about 2 years ago from UCLA, indicating more like 1 in 2. And they also indicated it's not just 60 years and older, it's 30 years and older. The other thing to think about is both of these studies were done based on just looking at fasting blood glucose and hemoglobin A1C. Neither one of them had OGTT. Neither one of them looked at an insulin survey. And as patients are finding over and over and over again in the webinar, and as you see in comments on our channel, Docs tend to just use hemoglobin A1C and fasting blood glucose, and they're missing a huge number of folks with not only insulin resistance, prediabetes, but full-blown diabetes, telling their patient that they're fine. Again, some of the things that we go over in the webinar, this is an optimal OGTT, fasting blood glucose at 80. At 1 hour, not getting over 120, and then at 2 hours, getting back below 100. As you see, these are not optimal numbers. That's what the lab puts down. That's what they consider normal. This is one of our patients, one of our folks said, my blood sugar's fine. Very sharp guy, knew it. In fact, it was John Norscheider. He did a video on this, over a year ago. And he pointed out that he first came to me saying, I know you focus on this issue, doc. I will go ahead and humor you, but I'll tell you beforehand, I'm fine. My doc checks me twice a year, and I check up on him. So I do not have a blood sugar problem. Once he did a Kraft insulin survey, we saw blood sugars going up close to 300. So I'm not going to get too much deeper into the insulin survey, the OGTT. I'll just talk about one other thing that we can do to help people look for that metabolic storm, things going on that would help us predict and prevent a heart attack. CIMT. CIMT will tell us if we've got soft plaque in our arteries. And we've got, again, plenty of information on that. Clyde's actually doing some work to not only clean up and operationalize the webinar for the labs, we're also going to start a webinar program for CIMT. David Meintz is out there getting a lot of, giving people a lot of access to the CIMT, getting it done. He just did one last week in Austin, Texas. And we're getting more and more people who are coming in and saying, you know what, I'd like to have a little bit more information on how to interpret my CIMT results. So what we're going to be doing is setting up a webinar, not only for OGTT inflammation studies and insulin resistance, insulin survey, but also a webinar program for CIMT. So with that, I'm going to end the show, come back out, see if there's anybody on the line. Okay, we've got about 84 people. Terry Dukes, first timer who missed, oops, I've got something going on here. First timer who missed a screening. Yes, I'm familiar, Terry. Haven't given up. So what happened was, it was very frustrating for all of us. Terry came to the Austin event as a first timer. We're not sure if she went to the wrong hotel or spoke to the wrong person at the hotel, but she was unable to get access to the CIMT. She wrote us. We scrambled around to try to get access and information back to her. Unfortunately, everybody else was able to find the room and get their CIMT, but Terry wasn't. Thank you so much for attending, Terry, and thank you so much for your patience. I know you drove an hour to get there, and again, thank you for continuing to push that. I know I spoke with Heidi, and she says she's working with you on helping you get access to the next one that's nearby. John Tocho, I'm having my grass-fed organic plain yogurt with monk fruit. So that's good to hear. Yeah, it is good to hear. In fact, if I can organize this to where we get back to that, I'd love to show folks what our brain looks like on sugar, what our brain looks like on saccharin, and talk about I've recorded a video recently where I talk about my own sweets addiction. And sweets is an addiction, there's no question. Bart Robinson, good morning, Dr. Brewer and all viewers. Good morning to you, Bart. Thank you for joining. Here we go. Tom Hudson, good morning. I also missed the CIMT in Austin. Will there be another event in Texas? Well, here, you know what? You bring up a really good point. Let's go back. I'm going to do a share. and show us how to find that out. If I can set up the share correctly. Let me see. Okay. So hopefully you see my website, or you'll see it in just a minute. If you go to www.prevmedheartrisk.com, you'll go to our website. Go to the membership login. And if you haven't logged in yet, it's free. Just it'll ask you for your email address, and you can just go ahead and get set up for membership. Now, if you'd like to find out, do we have a CIMT event in Texas? Go to, there's live webinars here, second live webinar here, and the CIMT events. And I'll go back up and explain what that live webinar means. But let's look at the CIMT schedule. Okay, Healthy Life Texas Mini Summit, February 15th in Austin. The next one is April 4th in Detroit, Michigan. The next one is April 17th in Central Western Ohio. Here's another thing to be aware of. The ones where I'm doing them, Janice and I are doing them, you can get a full-blown evaluation. You can call in, you can get your labs beforehand, and we can see you as a patient. Let's see where else. Rochester, New York, April 25th, Memphis, Tennessee, May 2nd, and July 25th in Portland, Oregon. So that's the schedule, and that's how to find the schedule on our website. The other thing is the webinars. So let's just take a look at that real quick. If you've joined the webinar, you can go in and get access to the information. For example, October 22nd, folks who were in the October 22nd webinar and this series of webinars can go in, get access, and see what happened there. Second webinar, same thing. You get access. So what happens is once you sign up for the webinars, you get access like a subscription service to the information that we're covering. And again, one of the most powerful pieces is patients learning from each other and seeing the context. Usually when you see a doc, you hear the doc's description of his or her view of the world. You don't really see his or her view of the world. You don't see other patients. And again, that's the way that we do the webinars. You don't have to share your own information, but you certainly can. And we discuss where you are in context with other folks. Again, very, very helpful for a lot of folks, and we've gotten great feedback. So that's the live webinar series. Just while we're in here, to talk a little bit more about the membership site, the free membership site. So you can go in if you'd like to learn a little bit more about inflammation. We've got a course on inflammation. It's what, $29, $39. You get free information. There are sections of the courses that are out there and available for free. You don't even have to pay for the previews. Insulin resistance course, for those of you who are interested in learning a little bit more about the insulin resistance course. These courses are set up where they take you in less than 2 hours. You can see all the videos, read all of the text associated with each of the classes in the courses. And again, in less than 2 hours, understand far more than most docs do about insulin resistance, cardiovascular inflammation, plaque evaluation. As you see, the plaque evaluation course has each of the classes, each of the topics here available to you. We also have a free preview of the upcoming book. One is the introduction, a tragically common story about plaque. The second one is stress tests, how not to measure plaque. So again, gives you some information on a teaser on the book, so you can start understanding what that's going to look like. We also have some infographics available for those of you who are interested in taking microseconds, 15, 30 seconds to take a look at something and learn a little bit more about oral glucose tolerance tests versus the Kraft insulin survey. This helps you understand the differences between those two. For those of you who are trying to figure out the difference between prediabetes, insulin resistance, and metabolic syndrome, we've got an infographic on that. Cardiovascular inflammation, again, we've got an infographic on that. And that infographic goes into the details of the different tests we use on a standard cardiovascular inflammation panel. So I'm going to jump back out now and take a few more questions. Let's go back and see if we can, there we go. Let's stop the share. Okay, does the artificial sweetener aspartame cause insulin to increase in the blood? I don't know this for sure, but I have not seen where any of them cause significant increase in insulin. Now, if you go back and you read about it, you'll see statements in the literature and the science that say, oh yes, there is some impact on insulin. The reality is when you start looking more deeply, again, I don't think I've seen any studies yet which are clear in terms of, yes, you get huge increases in insulin from artificial sweeteners. Bob Weiss, good morning, Bob Weiss, North Georgia Mountains. Good morning, Bob. Robert Pinsky, good script for, got a script for Freestyle Libre. I'm pre-diabetic. Amazing learning how food and exercise affects glucose, like a 14-day OGTT. I recommend it to everyone. Thank you very much, Robert. I'm going to repeat that. Folks don't understand. People are flying blind in terms of the impact of exercise on their blood sugar, the impact of food on their blood sugar. If you read Jenny Rule's book, she says over and over again, her book, she's got several books. Blood Sugar 101 is her most popular book. And she talks multiple times about eat to the glucometer. And now that the Libre is available, it's very inexpensive. It's not like $800 total like you get with a Dexcom 6. Dexcom 6 is great. In many ways, it's better. It's more accurate. But, it's $300 for the placement. It's $300 for the sensor. It's a lot of money. Otherwise, you can do like Robert Pinsky, get a 14-day Libre button, put it on, and start learning this very quickly without a lot of financial investment. Venu Gopal, hello, doctor. Good evening. I don't work out at all, and my resting heartbeat is 85. Am I normal? Number one, it's not healthy to not work out. And number two, a resting heart rate of 85 is not good either. Cholesterol test should be done after 14 hours or 12 hours. We routinely get cholesterol tests after 8 hours or more. Okay. Unfortunately, we've got a lot of participation, a lot of activity, and my screen just jumped again. John Tuccio, I'm going to start here. John Tuccio, I wish there was a place in Minneapolis where I could get a CIMT. John, if you will write cardiorisk.ford. Oh gosh, somebody please remind me, help us out. You can sign up on our CIMT access, and you can call our program. You can call 859-721-1414. That's 859-721-1414. And these folks can give you the telephone number for Heidi. She manages and coordinates the CIMT access tours. They have folks going to doctor's offices throughout the country on a regular basis. You know, each of the CIMT techs has like a milk run where they go to this one this week and the next one next week. So you should be able to get access to a CIMT. You just need to know how to do it. So I think it's this. I think it's cardiorisk.us/forward, and then that will help you. That will help you get signed up for the next CIMT tour. AJB, how can I get accurate blood sugar testing here in Atlanta? Well, I'm going to key on for a second on the term accurate. A lot of people don't like the Freestyle Libre. They say it's inaccurate. Yes, it is true. You occasionally get some inaccurate buttons. And for that reason, I always recommend that you get a Freestyle Lite blood sugar monitor or blood sugar finger stick test and have that to check on your Libre. But what most people, especially people that get frustrated about the Libre, often don't realize is that accurate is a relative term. Routinely, when I do a lab component for patients, like if they come to the event, if they are on the webinars, we'll often get fasting blood sugar in 2 different specimens. The specimen was drawn at the same time. It was just put into separate pipettes. And here's the thing. We'll routinely get a difference of up to 10 on fasting blood glucose on those numbers in a reference lab. So you get that kind of change and you begin to realize this idea that I'm going to get a quote accurate number is, you have to understand what accurate means, and you have to be focused on patterns as opposed to thinking there's going to be one number and it's going to be written in stone. So back to the question, how can I get an accurate blood sugar test in Atlanta? Well, there's a whole bunch of ways to get blood sugar testing all over the country. Quest lab sites, again, you can call us at 859-721-1414. That's 859-721-1414. And our folks can help you get a Libre, get labs set up through Quest, other draw sites, things like that. C-Lear, how reliable is the omega-3 index test? I think that's a really good question. I don't use it a whole lot, and that's my concern, the level of reliability of that test. Thanks for your generosity in providing so much information. Well, thank you very much for the acknowledgement, C. Cotton Forest, is it safe to take K2 MK7 even having 69 calcium score? The answer is yes. A lot of people get very concerned about, okay, if I take vitamin K2, is it going to suddenly loosen all my calcium in my arteries, in my plaques, and then therefore loosen the plaque, and then therefore the plaque's going to break off and cause a heart attack? I have never seen that. I don't think that's actually the way it happens. I think that, and in fact, I don't think the same thing that everybody else thinks about vitamin K2 anyway. Here's what I think. What I think that is that vitamin K2 impacts enzymes like osteocalcin. Those enzymes are in turn some way, and we don't understand that, but in turn some way related to insulin sensitivity. So I think what happens with vitamin K2 is that it does help insulin sensitivity. In fact, I have found one study, it was a clinical trial, it was a small one, but it did indicate that it was improving insulin sensitivity among relatively young insulin-resistant men. Now, if it's improving insulin sensitivity, your body will then go back and resorb calcium, resorb to a large extent, and resorb plaque. So I think that's the way that vitamin K2 works, improving our overall metabolism, not doing something where it just comes in like a vacuum cleaner and sucks calcium out of plaque. You do hear and see that statement that fear stated quite a lot in discussions, internet discussions about that. And I don't think that's a valid fear. I, by the way, have plaque. I can't remember my number on my calcium score. I think it was like in the 90s. And I take K2. I take a supplement of K2 with, it's either 1 or 200, I think it's micrograms. I'm blanking on the unit there. I also each morning take natto powder. So I get K2 in a couple of different ways. Big MIG, B-I-G-M-I-G. When I went to my doctor, my A1C was 4.9, but my fasting blood sugar is always a little over 100. What are your thoughts? Well, you bring up a really good point, Big MIG. Most people that get focused on dawn effect, fasting blood sugar elevation, in my experience, really get too focused over something that's not too big of a deal. Now, why is that? And what am I talking about? Well, if you look at fasting blood sugar, there's a thing called dawn effect. For those of us who don't understand what we're talking about with dawn effect, I'll go to at our events. We'll usually have fasting blood sugar for people that have not taken them before, and we'll usually find between 10 and 20% of adults attending these meetings have a blood sugar that's higher when they're fasting in the morning than it is after they eat something. Now, why is that? That's because cortisol, a hormone that increases blood sugar, peaks in the early morning, 3 to 5 a.m. Now, why did I say that people that get really concerned about the dawn effect are often overly concerned? Here's the thing, with dawn effect, you get increases into the 90s, 100, 110, 115, I think was maybe 120 once I saw on dawn effect. But you don't see 140, 160, 180. You don't see that. And those are the kind of numbers that burn the glycocalyx, not so much 100 to 110 that you tend to see with dawn effect. So, Big Mig, I don't know if that answered your specific question. Well, yeah, you asked what my thoughts are. My thoughts are people get a little bit too concerned, I think, about fasting blood sugar, and too concerned about dawn effect. Now, here's the thing. I think it cuts both ways, and I've already said that a couple of times, even in this video today, that fasting blood sugar is often way too low in terms of trying to judge whether you've got a problem. Hemoglobin A1C is not going to tell you whether you've got insulin resistance and or even diabetes or prediabetes, and fasting blood sugar isn't either. Those tests are inadequate to tell you whether or not you have that metabolic storm, cardiovascular inflammation, insulin resistance, prediabetes. We routinely will get people that say, hey doc, you know what? I took your test, I got an OGTT, and just like others have said, my doc's been telling me I was fine. I thought I was fine. And not only do I don't have prediabetes, I've got full-blown diabetes, and we didn't know it. So again, don't depend on fasting blood glucose. Don't depend on hemoglobin A1C. Get an OGTT. And while you're in there getting the OGTT, just get insulin values with each of the blood draws, and that'll give you your body's insulin response. Okay. Terry Dukes, thank you, Dr. Brewer. Our family practitioner doc doesn't even know the CIMT. We have butted heads with him constantly over keto for the past 2 years. We take our blood sugar daily, lighter and healthier. Very good. And again, we've had discussions. There've been research, there've been studies done about why and how much family practitioners, how much primary care docs know about diabetes, prediabetes, how much they care for it, what they do to care for it. And the bottom line is it's inadequate. Everybody who studies this stuff knows. I'm not telling stories out of school, and I'm certainly not criticizing docs. I've made a living out of supervising docs, and they're people just like the rest of us. They're pushed right now between insurance companies forcing either poverty or very, very short patient interactions. Then they've got standards committees on the practice of medicine that don't really understand how to deal with a lot of stuff. For example, the ACC, American College of Cardiology, American Heart Association, still stumbling around, as I mentioned before, with how to deal with cardiovascular inflammation. That college, as well as the U.S. Preventive Services Task Force, finally, over the past few years, starting to thaw out a little bit on CIMT. And again, in the book, we go into depth and detail about the science behind CIMT and why the standards, medical standards committees have been so slow in terms of sifting through the science and understanding when to use it, how to use it, the value on it. Daniel Christopher, good day, doctor, from England. Good day, Daniel. It's probably evening your time. Good evening. Eric Jantz, do you still get all the benefits from intermittent fasting? Let's say 24. So that's an eating window, I'm assuming, 4-hour eating window, which sounds like 1 meal a day. Oh my. Although you still have glycogen in your muscles. Thanks. So yes, Eric, that's a really good point. I'm glad you bring it up. And here's my perspective. Even those, yes, there's no question. If you saw the video a couple of weeks ago, we've got a couple of versions of the video out. The recent New England Journal article from December 26th of 2019 on intermittent fasting. It was a very good introduction to the science around that. And I was very excited to see it out there, and it was saying, like everything else, the standard medical community is just not there yet. Well, now with something coming out in the New England Journal, it's hard for them to argue, any doc to argue that it's bad science. Now, but that's not exactly your point. The first point is that yes, intermittent fasting is hitting prime time. The second point is, do you still get benefit from intermittent fasting if your glycogen, if your liver is still pumping out glycogen? Yes and no. Bottom line is that's why I recommend, and most of us who are in that space, Walter Longo, oh, I'm blanking on his name, the renal guy, and Senior Moment, the guy that wrote the diabetes code, fasting. I've done several videos on it. Anyhow, I think almost all of us would recommend that you don't just do intermittent fasting. You go ahead and do some episodes of prolonged fasting as well. Now, I will typically, the typical thing that I'll get with people that have really had a huge impact on their life, they've lost 30 pounds. I'll say, that's great. And they'll say, yep. And I'll say, how did you do it? They say, well, I went low carb. That decreased my hunger. I closed my eating window. For most of them, it just means I stopped eating breakfast. And then I'll say, well, what have you thought about doing any prolonged fasting? I don't get a lot of takers on that. Prolonged fasting, the first couple of times you do it, is a challenge. But then once your body hardens to it very well, and then once you get used to it, I think it is very, very healthy for the same reasons that you see in terms of metabolism and epigenetics that were mentioned in the New England Journal article that we talked about. What about constant, Smiley Blue, what about constant broken blood vessels in a 7-month-old baby? I don't think I should be trying to help on that, Smiley. Joseph Page, does the sugar itself injure the organs and arteries as does the insulin? Or are high sugar levels just an indicator of high insulin? I don't think anybody knows that yet. What we do know is that people that we do know that insulin alone does this, because we find people who are insulin resistant. They're taking up to like 100 units of insulin to keep the blood sugar down, but they so they're keeping the blood sugar down, but insulin is high. Those people get arterial plaque and inflammation. We also know that that people that don't have any significant insulin to speak of, they've burned it out, so they're getting high blood sugar values and really little to no insulin. Those people get plaque as well. So again, we know that both of those alone will cause plaque and inflammation. Naras Bhatt, MD. Thanks for joining, Dr. Bhatt. Why Asian Indians have more coronary disease? Is it ectopic fat? It's a really good question, Dr. Bhatt. We do know there are genetic tendencies in terms of insulin resistance and diabetes. We also know that ectopic fat is a really, really big deal. I did a video, a couple of months ago, and I titled it after another video I was covering. I think the name of it was The Secret Life of Fat Cells. The bottom line is, as you've mentioned, Dr. Bhatt, we used to think that fat cells were an inert energy storage mechanism or tissue. We have found since then anything but the case, or that the truth is anything but the case. Fat cells are very active endocrine tissue. They release things like leptins, adipokines, adipo meaning fat, kines meaning attractants. They release things that are hormones that drive insulin resistance. And for example, that is the most powerful thing that I'll tend to see in terms of causing inflammation, extra fat cells, or not extra fat cells. You don't get extra fat cells, you get growth of the fat cells that you have. Gary Simone, I think you're saying my calcium score was 600, but cholesterol was 120. Doctor says I was okay. Diet is plant-based. How is blood sugar a factor? Well, Gary, I given what I've just said, and given we got like 900 videos, and a huge portion of them are on this. I'm not sure what else to say, Gary. Hot Wheel 66, go Brewer. Well, thank you. Go Hot Wheel 66. Hull 39, Dr. Bhatt. In addition to Dr. Brewer, I'd suggest you search for Dr. Ranush Sinha, and he specializes in preventive medicine for Asian Indians. Excellent book on Instagram. Surya Kir. Is there a benefit in doing CIMT or CT angiography after calcium score tests? Yes, very good questions, Surya. And here's the thing. With recurring CIMT, we usually recommend CIMT every year, and you don't recommend calcium score every year. Once you get a calcium score, there's some people like Matthew Budoff who've said you can do some follow-up. And again, John on our channel once demonstrated clearly that you can do follow-up on it. It's not as good for follow-up as the CIMT. So CIMT will actually show you if you start off with soft plaque, for example, you can see flecks of, and start to calm down your inflammation, start to stabilize your plaque. You can actually see flecks of calcium get started, and then you can see full-blown calcification as it becomes a stable calcified plaque. And those stable calcified plaques are basically representing scar tissue. Instead of having soft plaque in there now, you have stable scar tissue. And for those of you who question whether or not that's actually more stable. There's a Honda study, Honda, that I've covered a couple of times. Is calcified plaque really more stable? John Grutzik, I lost 30 pounds. John, that's fantastic. That is a big, big deal. And that kind of weight loss, there is no surgery, no stent, no bypass graft, no medication, no supplement, no vitamin that can come anywhere near the positive impact on your life that losing 30 pounds will have. Congratulations, and thank you for sharing that. Hole 39, Jason Fung. Yes, again, thank you so much. Senior moment, Jason Fung. That's who I was thinking about a few minutes ago in terms of talking about prolonged fasting. Oh, really good point. Hot Wheel 66. Can't a calcium score miss soft plaque? Absolutely. We've had patients where that happened. The patient thought they were fine with some minimal, and in fact, it happens fairly often, where they're fine, they thought they had some minimal plaque because they had minimal calcification. Then you get them, you get them calmed down, you get their inflammation calmed down. And one of the things that often happens is you get a rise in the calcium score. And again, that's not because they suddenly laid down a lot more plaque, it's because they calcified the plaque that they had. Nobody nowhere. Should you eat most of the calories as breakfast, as is shown that you store less by doing that? And also breakfast is the best time to eat. Yes, there is, I think there's debate, but however, I don't think there's a lot of debate. Bottom line is when you start looking at the long-term studies, if you're going to narrow your eating window, it's better to eat in the morning and not at night. You may have picked up and you may be responding to my statement a few minutes ago that for most people, closing that eating window means skipping breakfast. And you'll hear many people say, breakfast is the most important meal of the day, don't miss it. I don't argue with any of that. The bottom line, though, is that, again, I'm a doc, I do this for a living, and this is what I see the vast majority of the time. Why is that? It's a social issue. You know, man is a social, human beings are social, and it's a heck of a lot easier to skip breakfast than it is to skip dinner. That's, I think, the reason behind this. So if you can, and I do have a few patients that skip dinner and not breakfast, and good for them. Okay, Ray, hello, Ray. Soundtrack TV, can long-term fasting help clear arteries and reverse calcium scores? It can clearly help, yes, there's no question. What do you think of nattokinase? I get a lot of questions about nattokinase, and I've been back and forth in terms of using it. Nattokinase does have a lot of opportunities. The problem with nattokinase, and I get beat up on the comment section all the time about this opinion, is that it's a simple protein, and I don't think very much of it makes it past the stomach acid. People say, Doc, don't you know that you've got an enteric-coated nattokinase? And the answer is yes, I do know that we've got enteric-coated nattokinase. And I know that most nattokinase is in an enteric-coated form. But go back and look at the performance of enteric coating, stomach coating, things that are supposed to protect a pill from stomach acid. They just don't work that well. Okay, and if they did, I think nattokinase would really increase significantly in terms of its ability to have an impact. Frank D, if I cannot get a CIMT for a few months, will a CTA be helpful? Definitely, yes. I would get one or the other. And clearly, CTA, I think you're referring to a CT angiogram. CT angiogram is a big up-and-comer. We docs are not that familiar with that yet. CIMT is a great one. It's the major one for doing obvious and clear follow-up and calcium score. Your typical docs, your standard docs, most docs do not know about or use any of those three. They tend to do the stress, you know, The typical transition. Hey, let's get a stress test. And oh, look, I saw something on the stress test. Let's take you to the cath lab. And oh, you know, once you get there, they're usually going to see plaque in the cath lab. And then it's like if you're a hammer, everything looks like a nail. If you're a cardiologist and you see plaque, it's tempting to think about stenting it. That's an overstatement. The cardiologists have done a great job in terms of cardiovascular intervention. We're just not where we need to be in terms of medical leadership with the prevention side of the house. Liana Mori skipped over my question. Liana, as you may tell, it happens to me over and over and over again as more questions get sent in, they move my screen. So you're going to have to repeat. I apologize, but you're going to have to repeat the question. Joe Grutzik, hey, start with a 3-day water only fast. It changes the way you see food. It makes intermittent fasting easier. Joe Grutzik, thank you for that, that suggestion. And yes, it's true. The first time you do any kind of fasting is hard. The second time is a lot easier. Third, fourth, fifth times, it just continues to get easier. Bob Weiss, triglyceride over HDL about 1.0 for years. Is this an indication of a reasonable IR? It is. I have seen people with insulin resistance problems that have good triglyceride over HDLs. Why that happens is not very clear, but it does happen. But yes, that's a strong, if you've got a good low triglyceride over HDL, that's a very good indicator that you've got good carbohydrate metabolism. Kenpa 2, are there genetic factors that result in damaged endothelium? Some of us have a family history of early heart disease, but show no risk factors, blood glucose, lipid panel, etc. Well, Kenpa 2, that is a great question. I will tell you, 9p21. Many of you have heard of the book, Beat the Heart Attack Gene. Well, the heart attack gene that they're referring to is 9p21. Ninth chromosome, the p21 area. There are actually a lot of SNPs variations in that p21 area, which can create this kind of risk. Most of them cause diabetes related items, but some of them actually cause problems with the artery wall itself. And I did a video on this, gosh, I think it was about a year ago. So if you go into our YouTube channel, you look up Ford Brewer 9p21, you'll probably get about a half dozen videos on 9p21. Look at one of the more recent 9p21 videos, and it does cover that. Thank you. Very good question. Okay. Again, getting a lot of good questions, and that's moving us through. I apologize. I'm not going to be able to hit all these questions. Rick, I was on high dose vitamin D for 6 years. Each year, my calcium score went up, and now it's a few points over the maximum. I'm off the vitamin D now, and what can I do to lower my calcium level quickly? Well, a couple of questions, Rick. The first question is, what is the maximum? I've got several patients with a calcium score over 1,000. They came to me, most of them came to me very concerned about it. We were able to slow that down and stabilize that, and they've become very comfortable with where they are. Number two, I think as you may have heard through some of these discussions, that first of all, you need to find out why you were developing the inflammation. And as I said, one of the most common causes is insulin resistance. You also get other reasons for getting inflammation too. Most people don't know this, but rheumatoid arthritis, one of the classic inflammatory diseases, also is a significant risk factor for heart disease. The other inflammatory diseases often cause that kind of risk as well. You see other things like elevated homocysteine, an indication of being a poor methylator. You see other things like elevated Lp(a), which I mentioned earlier about Bob Harper. All of these things are things that can cause inflammation and therefore elevated calcium. I have to tell you, knowing what I know about this process in this space, I'm very skeptical that vitamin D caused your elevated calcium scores. Ray, thanks for answering my question. Again, I apologize about missing that other one. Daniel Christopher, Doc, how does high insulin resistance in type 1 diabetes damage your glycocalyx? I don't think anybody knows that very well yet. I have some personal theories. You know, glyco in the term glycocalyx means sugar. So one of the things I wonder is these hair-like appendages in the glycocalyx are mostly made of sugar. So does having a higher level of sugar in your blood, does that tend to dissolve these hair-like structures? I don't know. I don't think anybody has the answer at this point. And Andrea Thomas, hello, I love your channel. Well, thank you, Andrea. I appreciate that. My blood pressure is 130/98 most days. I was told it was a side effect from my rheumatoid arthritis infusions. I've been trying to get a blood pressure medication. Yes, I think you should get a blood pressure medication. People say, well, 98 diastolic might be okay. It's not a big risk. It's a risk. You know, our goal should be not to live for the next 10 years. It should be to live for the next 30 years. And having a diastolic blood pressure close to 100 is not a good way to do that. We need to get it down there, closer to 80. All the blood pressure medicines have horrible side effects that I can't tolerate. Do you have any advice? Well, I think I would. I can't give people individual advice on individual medications over a public thing like the internet. But if you'll call 859-721-1414, 859-721-1414, we may be able to get something set up for you. Okay, Terry Dukes, I'm a poor methylator. One copy of 677 CT. Do you think it makes me insulin resistant? I don't think it's clear yet in terms of poor methylation causing insulin resistance. I think what is clear, though, is that poor methylators do have more problems with insulin resistance. You know, if you listen to people like Z-Dog, he's a physician. He's I think an internist or something. He's an intensivist, does a lot of hospital work, and he's come out talking about methylation. And he says, yes, it's real, but it doesn't matter. He hasn't studied the science in this space. Yes, it does matter. Methylation is a way that our body deoxidizes. You know, you've got oxidation and then reduction. If you go back to your high school chemistry class, well, reduction is just adding a hydrogen atom back, or a hydrogen electron. Our body doesn't, we don't do it that way. We don't just add a hydrogen atom back, we add a methyl group back. And again, up to half of us have 677 CT, or the other one, is it 1298? Can't remember, but up to half of us have a problem with methylation. And those folks do get earlier damage from insulin resistance. I don't think it's because it makes us more susceptible. I think what it does is decreases our ability to clean up that oxidation that is occurring associated with insulin resistance. So guys, we are getting over beyond a 1 hour. The folks that tune in to this video will be on, it'll be posted automatically. The folks that tune in for views after the fact start to see these 1 hour plus times, and they start saying, you know, I don't have time to listen to all that. So I try to keep it to an hour or less. Thank you very much for your interest, and I'm going to sign out. Oh, I was going to say, see you next week. I hope to see you next week. We are again on the road. We're getting ready to go down to Orlando to do the event. We hope I will be able to do the live next week. Maybe, maybe not. We will put out an email announcement. Thank you again for your interest.